Started. I'm Dr. Andy McLean. I'll be facilitating today's Project Echo Clinic. This one is the Substance Use Disorder Assessment and Interview Skills for Primary Care. And I believe that Julie had previously sent out links to the pre-test, post-test, evaluation, et cetera. So just want to remind you to do the pre-test if you're looking for CME or CEU credits if you haven't done so already. And just a reminder, the red, black, and white Project Echo signs denote subject matter experts. Just the procedures, most of you are used to this. If you would mute your audio when you're not speaking. If you have questions, you got a couple of options. You can unmute and ask the question, or if you don't want to interrupt the speaker, you can certainly just use the chat feature, and then we'll address that. I'd like to thank Kylie for stepping up and helping out today in Julie's absence. And just in terms of introductions, our didactic presenter is Brynn Luger, and Brynn's a colleague of mine from our DHS days. She's a licensed professional clinical counselor and national certified counselor. She's currently a doctoral candidate at NDSU in counselor education and specializes in working with, adults, adolescents, and couples. And she has particular areas of interest in Native American mental health issues, trauma therapy, and addiction. And after Brynn's didactic presentation, we'll open up for questions, and then we'll move into our case. And our case presenter is Wendy Moore, and most of you know Wendy, who graduated from Boise State with a Bachelor's of Science in Nursing, and then she went on to obtain her nurse practitioner degree from Gonzaga. She's a certified family nurse practitioner at CMS, and she evaluates and admits clients with opioid use disorder into the MAT program. Prior to that, she had worked at Manor Care in Fargo and was essentially managed the facility. And she has lots of ICU experience as well. So both individuals today are very experienced, and we look forward to hearing from them. And Brynn, if you want to go ahead and take over.
All right, I sure can. Thank you, Dr. McLean. I'm going to get my PowerPoint up here, so hopefully that works. And can everybody see that?
It's black right now. Oh, there we go.
There it is.
Got it? Okay.
Yes, thank you.
I'm a little off on my slides here. Okay, so like Dr. McLean said, we're going to be talking about substance use disorder screening and interview skills in the primary healthcare sector. So just quickly, the objectives today, we're going to talk a little bit about substance use disorder, why this is important in primary care. We won't get too much into the diagnostic criteria, but we'll just touch on it briefly. Then we're going to talk about the management of substance use disorder in primary health care. Then we'll go into physician interview skills. And then we're going to talk about different screening and assessment tools for substance use disorder. There's many, many, many tools, and I've chosen 3 to highlight today. So we'll talk a little bit more in depth about those 3. And then finally, to wrap it up, we'll talk about referral resources, online and locally and nationally that are available. So to start us out, why is this important? Well, there's a high prevalence of mental health and substance use problems in America, as many of you I'm sure know. And as if that's not bad enough, many Americans end up going without treatment. One of the reasons is because they're not properly diagnosed. And that's where a primary care physician's screening will come into play. So the hope is that primary care will adopt and be utilizing more screening techniques for substance use disorder, which will then result in earlier care and treatment. Just a side note, when we're talking about screening individuals for substance use disorder, it's important to remember that we're looking at people of all ages, and that includes young people, adolescents, and all the way through elders who have a tendency to struggle with some of these issues too. So we don't want to highlight just one population and screen them. We want to make sure that we're kind of capturing the whole gamut of patients that we serve. Little bit about substance use disorder. This is the information from the DSM-5. I like this graphic because it kind of groups the criteria into like themed areas: impaired control, social impairment, risky use, and pharmacological. And I'm not going to go through what the requirements are for a substance use disorder diagnosis, but 2 or more of these are needed in order to qualify for a DSM-5 diagnosis. And it's important to note in the DSM-5, they do specify between alcohol, opioid, marijuana, nicotine, caffeine, different kinds of substances. So keep that in mind when you're working with individuals on screening and diagnosis. Okay, so on to management of substance use disorder in primary healthcare. So these are kind of the 6 highlighted themes I wanted to talk about in terms of how primary healthcare can work with the management of people with substance use disorder. So first of all, we want to be able to identify them. We're going to get into detail a little bit with a couple of these, but to start us out.
If I could interrupt for a second, if somebody is not on mute, could you please do so? We're getting a little bit of background noise. Thanks.
There we go. Okay. So first step is obviously identifying these patients with possible substance use disorders. We're going to talk a little bit more about that process and how a physician's role goes into impact an individual's willingness to talk about substance use and their comfort level. Secondly, we want to stabilize the individual. So ensuring that the person is mentally and physically stabilized prior to going forward with any screening tools or any other interventions. The third is assessment. So we want to make sure that we're looking at a complete assessment of the individual, including, these diagnostic evaluations, but we also want to be mindful of co-occurring or comorbid issues. For example, if there's psychiatric issues, if they're dealing with schizophrenia or major depression or bipolar disorder, if there's any medical conditions that they're currently going through. It's also important to note, if a patient's going through any legal problems or stressors, psychosocial stressors like that. One we see a lot of is homelessness. That can be something that we want to make sure that we are talking about with patients and we're open about. Because substance use does not happen in a vacuum. It affects all sorts of different areas of people's lives. And certainly we want to make sure that we're being mindful of that. The fourth step then would be to plan. So we want to talk to the patient basically about the treatment plan and come to an agreement. I know most of you, or if not all of you, have had motivational interviewing training in the past. And that's a lot of the skill set that we're going to be using when we talk to people about substance use disorders. And I'll get more into kind of a quick review about motivational interviewing as far as aligning yourself and empathy and all those things. But the next step then would be to do referrals. And this would be for any specialty care that the individual may need, which includes obviously substance use treatment, medication, monitoring, psychosocial support, case management, and then anything other co-occurring conditions. Again, we want to make sure that we're touching on all of these areas with individuals. And then lastly, there's the follow-up. We want to make sure that we're keeping up with people. As you guys know, substance use disorder, one of the primary components we see with substance use disorder is relapse. And we want to make sure we're talking to people about relapse, prevention of relapse, and plans for how they intend to carry through with their sobriety and their recovery. So again, a lot of this, as you guys know, is dependent on the physician's attitude. People are more likely to open up if we're warm and we're inviting and we're non-judgmental. I think with addiction, that gets to be really tough for a lot of people, especially when they're coming forward with certain things that they may be ashamed of or embarrassed of. That's where that motivational interviewing of non-judgment and empathy really, really can help a lot. But to get into these first three a little bit more, identifying patients with possible substance use disorders. Obviously, this seems like an important step, right? In caring for people with substance use disorders, we want to make sure we can identify them. So in the management of primary health care, oftentimes I think we assume, in whether that's my field or any field, we assume that the specialists are going to take care of the specialty, when in reality, we want to make sure we're incorporating family medicine into this process, because it is such a huge opportunity to identify individuals and build this relationship, give information, all of these things. So just something to be mindful of. Oftentimes you'll see patients who come into their clinic, family medicine clinic, and try to and either seek services, or sometimes they refuse treatment. So that would be a time it's appropriate for a family physician to kind of head this up, especially if that person's engaged with the clinic already. They're coming back for medical appointments. They know the nursing staff, they know the lab staff, all of that. That's a really good way to kind of build that relationship with patients if they're a little hesitant about formal addiction treatment. The other way that this would be appropriate is if the patient has any serious comorbidity that would kind of prevent them from engaging in addiction treatment. If they're going through chemotherapy or something like to that effect, we could have family practice and nurse practitioners step in and try to fill that role in the meantime. And secondly, a lot of times we see chronic relapsers, people who have been in and out of treatment dozens of times sometimes, with little or no success, and they're in your office, at your doorstep talking to you about this. This might be a chance to do something different. I know when I work with individuals who've gone through multiple treatment settings, they start to tune some of that out because they think, well, I could teach the class. I've been here so many times. So if we change the environment and we change how we go about engaging them, that can really kind of be a good opportunity for family medicine, but for mental health as a whole. Secondly, ensuring stabilization. So basically what we want to talk about here is detoxing. We want to make sure, and this is kind of right up your medical guys' alley, but we want to make sure that we're assessing if they're medically compromised or not, and if they need to go through a detox process. Another thing about the detox process, some individuals are very familiar with it and some are not. So just being mindful that for some of these individuals, detoxing can be really scary and be really kind of confusing for them. So we want to make sure that we're talking through each step of the way in terms of whether they're admitted to a hospital or emergency room or things like that. I think sometimes people have a tendency to say, okay, now I'm flying off to the ER, now what? But they kind of don't really know where they're going. So if you kind of map that out for them a little bit ahead of time, sometimes that can be beneficial for them. So the assessment and diagnostic evaluation, that's kind of what I wanted to talk more about today, is the assessment part of things. So we're talking about patients, the people we're assessing are those that we suspect may have an addiction, who we presume has an addiction, or if they themselves have identified having a substance use disorder. And what we want to do is take that medical history, doing the physical exam, including a mental status exam, and then obviously doing any lab work or any other medical interventions as needed. And then we're going to get more into the assessment phase. So how do we do that? I kind of brought it up a little bit, motivational interviewing. I'm sure a lot of you remember your past trainings for motivational interviewing. So I'm not going to get into detail, but one of the things, I just included this stages of change diagram in the corner just to remind us of when we meet with a patient, trying to quickly assess what stage of change they're at. That can make a big difference if they're in pre-contemplation versus contemplation, etc. But the highlights that I wanted to take away from that, from motivational interviewing, are the following principles that I think are important for all clinicians and certainly family physicians. The expression of empathy. When I do motivational interviewing training, I talk about empathy and non-judgment probably ad nauseum. They really get an earful about empathy and non-judgment, because that is the quickest way to gain rapport with somebody is if they feel you're not judging them. It's really, really hard to admit some of this stuff and to talk about some of this stuff. So if we can express that empathy that, yeah, I bet this is hard and I'm sure it is difficult, that can go a long way. And remember, with motivational interviewing, we want to just develop discrepancy. So we want to look at what their actions are, where their goals are, and are they meeting? Chances are probably not. If they're at the point of substance use disorder and having an issue in the doctor's office, they're probably not meeting their goals. So we want to look at that. You say you want to attend college, but you're drinking every night or whatever. But we develop that discrepancy with them. And again, we do it in a soft, nice little way so they can hear it. Rolling with resistance. Remember that. Don't argue. And I know that seems like communication 101, but you'd be surprised. Avoid arguing. You know, sometimes people aren't there. They're not ready. They're in pre-contemplation, or they're in contemplation, or they've just recently relapsed. They're not there. So we meet the client or meet the patient where they're at, supporting patient self-efficacy. I also talk about this when I do motivational interviewing training, that we don't cheerlead just to cheerlead. We don't affirm them for breathing, but we also want to instill confidence that is genuine. And doesn't feel condescending or, yay, you're doing it, you know, type of thing. So we want to support their self-efficacy and, of course, use the OARS techniques. And if we were all in the same room, I'd throw a candy out to the first person that could tell me what OARS stands for. I wonder if anybody remembers from your motivational interviewing days. O is what? Open-ended questions. A, assessment. R, reflection. S, summarization. Okay, so just remember those skills. Again, I'm not going to get totally, in depth with them, but it's a good little reminder. So screening versus assessment. Now I want to talk more about these assessment tools that we could actually utilize and use in our clinics. So when we're doing screening, this is kind of more of a yes or no. The initial screening of, yes, this is an issue for somebody. No, this is not. From there, that determines where we go with the assessment and diagnostic phase. So the screening comes, then the assessment kind of furthers that diagnosis and recommendation process. Being mindful, of course, of any effects that culture, language, race, religion, sexual orientation, economic status may have on an individual's screening or assessment results. Just being mindful of that, of course, is always important. But so we're going to talk about, there's a couple different kinds of tools out there, or there's many different kinds, but two categories. There's the brief screens of 6 or less, and there's the longer written questionnaires. And depending on your clinic and your time availability, is going to depend on which we go with or which we decide to utilize. Typically, we use the written ones more in a clinic setting, just because the patients can often fill those out while they're waiting, or, that can kind of be a little bit, kind of expedite the process a little bit, whereas an oral screen takes a little more time. Some of it you need specialty training to do, to administer certain tests. So just being mindful, again, of which tests we're choosing and why. But this is not even an exhaustive list. This is a list of all the tools that are out there. And if I just ran through these acronyms, I think our heads would be spinning. So I'm just going to go with the top 3. The 3 that I've identified as the most commonly used. That's the audit, the assist, and the cage. And I don't know if anybody has familiarity with any of these or has experience with these that would be of note for the group. But ultimately, we're going to start with audit and talk about assist, and then we'll end with cage. Okay, so audit and audit C is for alcohol use disorders. And I've given some information here about the actual test. It's 10 item for the longer. Audit C is the shortened version. That would be more of the one you might want to give for a pre-screening. That's a 3-item test that you see, if you can see in the upper right here, it's the audit C questions are listed. How often do you have a drink containing alcohol? How many drinks containing alcohol do you have on a typical day? And how often do you have 5 or more drinks on one occasion? That's the brief screen. If they answer positive for that, then we move forward with the longer form of the audit or other assessment tools. There is also a drug, a specific one for the DAST is the audit, but modified for drug use. So let's see. This one can be administered by health professionals or by a paraprofessional. So you do need training to administer this. So the audit and the audit C should not be given out by non-trained individuals. As far as the details of who can be trained, I would have to look into that and see what they specify in terms of requirement, if it's, you know, CNA, nurses, whoever. But so that's the audit C in the audit. So the assist is the alcohol, smoking, and substance involvement screening test. So this includes alcohol, drugs, and nicotine, which is kind of, I think, a nice whole picture of somebody's substance use. However, this one is a little bit more lengthy. It's only 8 items, but it takes about 5 to 10 minutes to complete. And this is done through an interview process with a professional healthcare worker. So again, this isn't necessarily one you're going to hand out in the front desk for them to fill out in the waiting room. This would be more of an in-office type thing. But the assist is good with identifying multiple, like I said, multiple substances, and it teases that out a little bit. Instead of quote unquote drug use, it breaks it down into amphetamine use, marijuana use, etc. So you get a better idea and more specific in terms of what drugs and how often, things like that they're using them. I just included the screenshot from the first question. Obviously there's 8 questions there. So, but that's just kind of what it looks like. It's all yes or no. In addition, the scoring for the assist includes recommendations. In the lower part there, it says whether they score low, moderate, or high will kind of indicate where we go in terms of just providing education versus looking into treatment centers. So it gives us a little bit more direction in terms of what the test standards are. And finally, the big kahuna, the most popular, is the CAGE. And the CAGE has been modified to the CAGE aid, which includes alcohol and drug use. So this is 4 items. It takes less than a minute. It can be administered by anybody. The front desk can give this out. Anybody can give this out in your clinic. And basically, this is just a quick and easy little assessment. A lot of people feel that this is kind of more non-invasive. Some of the questions are worded a little bit differently than some of the other scales. So they feel this one sits a little better with people on average. But I gave an example again of the 4 questions here. Have you ever felt that you should cut down on your drinking? Are people ever annoyed with your drinking? That kind of wording can be a little bit easier for people to kind of grab onto, rather than listing, I have 8 12-ounce beers per night. You know, this is a little bit more like, yeah, my mom's on my case about my drinking kind of thing. So, and it opens it up for motivational interviewing wise, then you have a door wide open there to say, I see that you sometimes feel bad about how much you drink. Let's talk about that. Then that gives you a good chance to use those open-ended questions and build rapport with individuals. And again, where you go from here is really dependent. These are meant to, these ones that I highlighted are meant for assessment, not for official diagnoses. And obviously then if they tested positive or they scored a positive on these tests, then you would go further with the diagnostic criteria or a referral to an addiction counselor or something like that. But so these are just kind of a nice, easy way that we can get clinics moving forward with this, get people more accustomed to that when they do come to see their family doctor, they are asked these questions. It's not out of left field. All of a sudden I'm being asked about drug use. It's something that they can kind of become more accustomed to. Then slowly, the idea is then feel more comfortable bringing it up in their office with their physician. How am I doing for time? Oh, okay, good. So lastly, referral resources. So when we're talking to people about substance use disorder and they have a positive test and blah, 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 we talked about everything. We look at now what? Now how can I help them once they leave my office? So I wanted to talk a little bit about what the options are whether that's locally or nationwide. We have the 12-step support groups. They're not all 12-step, but support groups like Alcoholics Anonymous and Narcotics Anonymous. Online, you can find meetings in pretty much every town in America, virtually. There's many, many meetings per city. I mean, there's just a lot of opportunity for AA and NA. It is free, and with Rational Recovery, Smart Recovery, all of those, it's all that peer support type of stuff, which is really, really beneficial for alcoholics and addicts. SAMHSA has a treatment locator. Maybe some of you are already aware of this, but in terms of medically supervised withdrawal or detox, SAMHSA has a treatment locator where you can map out, put in your zip code and find, you can zoom in or out on the map and see where treatment centers are for addiction, mental health treatment centers, healthcare centers, medication-assisted treatment physicians who may help with opioid addiction, things like that. So it's a really, really good tool. I highly recommend. I put the link on my PowerPoint here, so if it does get emailed out to you, just check that out. It's actually pretty handy, and it would be a good resource to give patients so that if they are curious or maybe on their private time they're just wondering, gosh, I wonder if there is anything in town, they can kind of see visually where treatment options are in comparison to them. And then, of course, outpatient and residential treatment. So outpatient is obviously outpatient. They go home at night and they come back during the day and do their group work. This is a lot of group work, individual counseling. We're doing medication. We're doing stabilizations. With both treatments, you'll see a lot of family involvement. Sometimes with outpatient, you'll couple that with parenting classes or social services, things like that. And then residential treatment, of course, is that 24 hours a day care in a stable living environment, very structured, a lot of rules, a lot of things to get accustomed to. But I think, again, reducing that stigma in your office is always a good option, because residential is something that, gosh, people really get a lot from. And while on the outset, it's hard to hand over your cell phone or whatever, but in the end, you're doing something that's really, really good for yourself, and it's really taking action. So those are kind of, again, I know we're all from different places here, so I didn't want to get too much into the specifics about what Bismarck has to offer versus Fargo versus Minot. But I think this is kind of a good general overview of what we can provide patients with. And that's really all I have. I do have a list of my references here, but if anybody has questions, I have a few minutes before I have a client here that I have to see. So I'd be happy to talk if anybody has any questions.
Thanks, Brynn. Anyone have any comments or questions for Brynn?
Say, I got a interesting case. I was on call this weekend. Sorry, I missed the first part of your presentation. I was with a patient. So I had a patient come into me Saturday afternoon, was working the ER, and she admitted to being an alcoholic. And she says, I've tried to quit cold turkey before. She said, I think I need help now. Also suicidal. I ended up sending her to Prairie St. John's in Fargo is where we were able to find placement. And after she was there for 2 days, her father had called to get a hold of me on my day off, of course, and said that she wanted to leave now. She didn't want to stay there. They couldn't talk her into it. What do we do at that point when we can't get people to commit to inpatient when they really need to?
Well, certainly if there's any kind of imminent danger, we look at, I know when I worked at Southeast Human Service Center, we did a lot of investigations of voluntary commitments. So if it's an imminent situation, we would look at something like that. If it's not imminent in terms of life or death, I think, honestly, we go back to that motivational interviewing stuff. We try to align with them and get them to feel like they can talk about, without argument or without judgment, where they're at, what they want. Are they working toward meeting their goals? If their goals are getting their kids back, is leaving treatment the best way for you to get your kids back? Stuff like that. I think we go back to that motivational interviewing stuff.
Yeah, because I mean, she's functioning, you know, like when she came to me Saturday afternoon, she hadn't drank in over 12 hours and she still had a 0.18 blood alcohol content. And she goes, this is how I'd go to work, you know, and she's got a 10-year-old and a 12-year-old boy and she still has them. She still lives at home, but she says she binges 2 to 5 nights a week and will drink 30 beers. It's like, right now she doesn't have anything threatening, you know, against her use. I mean, she continues to live like this, but it's just like, you know, it's not healthy.
You know, yeah, and as you know, with addiction, there has to be they have to be on board at some level. You can't hang on their legs as they walk out of the office. I mean, if they want to go back out and drink, that is their choice, again, unless there's an imminent issue. But I tell a lot of the physicians I work with to think about natural consequences. Sometimes addicts have to feel the pinch of the natural consequence of their usage. You know what I mean? And that's hard as practitioners because we want to say, oh my, you can see where this is headed. And I can see this train headed this way and it's not good. Mm-hmm. But, you know, as long as she knows she has a support with you, you're not going to enable her, but she has somebody that she can turn to and talk to if she says, gosh, you know what, I was wrong. I should have stayed.
Okay. Yeah.
Kurt, do you have other thoughts on that? Still there?
Yeah. Sorry, I was muted. I guess, you know, sometimes there's key influential people in their lives. If you have releases, sometimes, you know, there's other family members or people that are influential in their life that you can partner with. There's also, you know, moments of clarity that come and go, and to be able to, and that's why access around treatment is so horrible and so necessary, is that when people are actually in a place to have that intervention, we need that access. So unfortunately, in your situation, you got her to a place, which is great, but yet she still was choosing to walk away. And of course, we have to think about our mandatory you know, obligation for child abuse or neglect if that was a situation as well. Which, you know, you hate to do that, but sometimes, because that's going to definitely impact your therapeutic relationship, right? They get really upset about that. However, it's another form of leverage if there's true risk to those children, and it is sometimes without a doubt necessary. So
true. That's good info. Thank you.
Yeah, and Kurt, that's a very good point. I was going to comment on that too. Much of what we have to deal with, particularly when they're moving from a higher level of care to a lower level of care, is, can we mandate anything? And as Brynn was saying, if we can't mandate it, you know, can we find motivation for them? Okay, if you don't want to be inpatient, it's clear that you want to deal with your drinking. What kind of an outpatient program do you think would be useful for you or work for you? And then the access issue. I think both with the question of child abuse and neglect reporting being mandated reporters, you do have to weigh that. And I've mentioned this before, and Grant, sometimes what I do is I've called up actually Child Protective Services and said, let me give you a hypothetical here. If I had a case like this, would you say that would fall into mandated reporting or kind of watch? And you know, sometimes that's helpful to help me to steer in the right direction. And then the commitment laws, and in North Dakota, you know, we certainly can commit people for addiction, but they're already in the higher level of care, and it's really up to that healthcare entity to make a decision as to whether or not they meet criteria. You may find something different next week on an outpatient basis, but you know, really Prairie would be the ones that would have to determine whether or not they could keep her.
Sure. Okay.
Could I offer one more thought too?
Yeah.
Sometimes, you know, we see them as needing inpatient, and obviously to be removed from the alcohol, that may be the case. But she probably has this, you know, what about my kids kind of feeling, and feels like I can't go away for 20 days or whatever. And so, you know, sometimes you know, the other options of potentially she's somebody that really struggles with cravings. So Vivitrol could be a really good option. And identifying, you know, maybe some other supports within the community. If you could just talk her into saying, hey, let's get free of the alcohol, and then let's see how we can put pieces in place in your own community to support you.
Right. If she's drinking to a 0.05 with naltrexone instead of a 0.18, that's a big deal. And the child abuse neglect issue is much less. I think, Dr. Schmitz, you had a comment or question?
Yeah, I was just going to, if we have time for one more question, just from a rural provider standpoint. I practiced in a town of 2,000 people for 6 years, and so I'd be really interested in people's comments about using these screening tools or assessment tools. It's, at least for me, it was a little different when it's your friends and neighbors who are coming to see you as a patient. In a town of 2,000, you may not know everybody, but you know somebody who knows everybody. And so I think we sometimes miss the opportunity to screen or assess in folks who are pretty functional, but could definitely have substance use disorder, opioid use disorder, and be good candidates for intervention. So what do y'all think? I mean, do you just kind of screen everybody? Do you just kind of wait for that trouble or conversation to come along? What's a primary care practice approach in a rural setting? That's my first question. And the second is, the opposite's true as well. I definitely had people on my schedule where reception or nursing would tell me, this person was just seen 3 times in the emergency department this week, and now they're coming to see you. So it's sort of, I felt like, set up a adversarial stance initially where that person's coming in for chronic low back pain. That's their chief complaint, but mine is, how, do I use a screening tool, and how do I slip that in there or utilize that intentionally? Or this is something we always ask all of our patients who have chronic low back pain. Or so just looking for a rural primary care perspective on the use of these tools.
I guess in my practice, no, certainly we don't screen everybody because, as you said, a small town, we got a town of about 1,300. So everybody does kind of know everybody. And just recently I kind of took a step back and just started looking at people I know, friends of mine, and I kind of went, geez, all these people would pretty much fail the CAGE questionnaire, without even asking them, because I know them. And I know our medical records, one of our quality initiative people or whatever was just kind of asking us on what kind of screening are we using for substance abuse disorder. And it sounds like something that they're going to be pushing here in our facility. That's just is mandatory that we have to do for everybody at their yearly physical or whatever. And I think that would be a good policy for these kind of situations when, I'm with my friend in the exam room and I say, hey, listen, John, here, let's be honest. Let's do this real quick. It's nothing against you. It's just something that our facility says we have to do, and we have to do it for insurance purposes. And I think that's going to help.
Yeah, Grant, I think that's a really nice way of going about doing it is, it's, even if you don't want to say it's not me, but this is, something that we need to do. And, I think most people will understand that. And I think hopefully be less defensive. They still might not be honest, but I think they won't necessarily blame you. Any other comments or questions for Brynn? So Brynn, thank you very much. And we will move on to Wendy.
Thanks, guys.
Yeah. So do we have Wendy on?
Yep, I'm here.
Great, there you are.
Here I am. All right, the case study today. I'm going to go over her history and stuff real quick. So number 2. This is a 35-year-old female with no known current medical problems, was admitted to our facility for opiate use disorder. On admit, she was taking pain pills orally since 2009, intermittently. So I found a lot of times when they first come in, this is one of the big questions that I ask them is, what's your opiate use? And their story changes as we go through our next half an hour. So her story changed from using occasional pills or intermittent pills regularly to pretty consistent. She said that started in 2013. She has been using Percocet 10-325s, 10 tablets daily. She said that initially she said she would just chew them up, but later said that she does nasally ingest them or snort them. She lives on the reservation, has her sister died of an overdose and her best friend died of an overdose. So she ended up with the best friend's 2 children. And then her sister's older children, one is 18 and one was like 21, plus her own 2 children, or 3 children. So quite a house full. one of the nieces actually got pregnant and was using methamphetamine, so she's trying to take care of that baby also, but it's got a lot of medical problems, so she's got that on her list too. So my problem, currently she is taking Suboxone 8/2 milligram tabs. She takes 1.5 in the morning and then 1 around 4 or 5 p.m. When she first started with us, I gave her a prescription for 7 days, and she came back after. She actually missed her 7-day follow-up because later she called us and said, well, I ran out too soon and I felt bad because I ran out too soon. So I didn't bother coming back at all. And so I let her know that it was okay and to come back in. So then she got herself a pill bottle or a pill box so she could cut up her pills and use them every single day and separate them out because it was too hard for her to have them in her hand and not take them all at the same time. On induction, also to be noted, I always tell them, take half a tablet, 4 hours later, take an additional half a tab if you are having withdrawals. And when she came in, she said, well, I asked her if she waited the 4 hours, and she said, well, kind of. And she went on to say that she waited 5 minutes. That was close to the 4 hours. So she ended up with 1 tablet twice a day, kind of, but she kept fluctuating because as an addict, she thinks she needs to take it throughout the day. So we worked through those problems over the last couple of months, and she's got the pill box, so she seemed to be making it last until her next appointment. But now suddenly she's got the additional baby that she has to worry about. Her boyfriend, apparently she found out, was abusing her children, and so she has to worry about CPS. And she's gotten back to the habit of running out early. So now she's running out a day early again. So she's at 2.5 tablets a day. So she's at 20 milligrams. Yeah. So the big thing to look at on this one is what kind of things should I do as an intervention? The boyfriend's been stalking her. He's got a lot of methamphetamine use. So a lot of everyday life things are really chaotic for her, but she's continued to be working and has way too much responsibility. So far, with all the factors playing in, I've increased her dose last time to help with the triggers, and which did seem to help. And she's very, very animated when she comes to me and says, I'm really trying, I'm working hard, this is working, it's working. I decreased her from monthly, which she got up to or earned to get up to. So we're back down to weekly. She was supposed to increase her time with our addiction counselor, and I encouraged her to do outpatient therapy. And I talked to her about a restraining order because she is actually worried about the boyfriend. So I guess any ideas or extra things or concerns with that case?
So Wendy, what dose is she up to now?
So she's on 1.5 tablet in the morning.
Yep.
So 12 in the morning and then 8 in the afternoon or evening.
Oh, okay. So you didn't go, okay. Thanks.
So that's what I went up to this last time.
So she's on 2.5 total per day, correct?
Yeah.
And what, is she on generic, or is she actually on the Suboxone or Zubsolv?
She's on the Suboxone. The Zubsolv, it's dosed differently. The numbers are different, but.
Yeah, right. The Zubsolv 8.6 is equivalent to like buprenorphine 12 milligrams, whether it's Suboxone or generic. And you said she's from reservation, so she has IHS?
Yep. Well, and that's an additional problem. So if they're with IHS, they can get treatment at the reservation, but they see everybody because they have to daily dose there and go in to get their Suboxone. They can't have this prescription. So if they're working at the bank or they're holding higher level jobs or anything like that, then they have a hard time getting treatment because they see all these people from the community there. So they are, I've got quite a few people that choose to come here, and they're actually paying out of pocket for the prescription and for the treatment program because the voucher doesn't cover them because they're in Minnesota. And the IHS doesn't cover their prescription. So they also have that financial barrier too that I haven't been able to work through.
Yeah, it's a little different here in rural North Dakota. The reservations that I work around, the pharmacies are happy to fill my prescriptions, even if they see me, so long as they've established care there. At the same note, IHS only carries Zubsolv brand name, so I'm limited with that. I was going to say,
the reservations take your prescriptions and cover them?
Absolutely. Yep. They have no issues with that. And I mean, in the two reservations that I work around, one doesn't have any MAP providers. The other one has one, I think. So it's difficult. So actually all my reservation patients have chosen to stay with me. None have switched care, even though I said, logistically, this seems to make more sense for you to go down there. And they said, no, I'd rather stay with you. And I haven't had any issues with scripts there. And the one benefit thing that I see with with IHS is say like Blue Cross Blue Shield or Medicaid may only cover, say, like 1 tab of this or 2 tabs of that, depending on dose. And it's kind of ridiculous. Just looking at my cheat sheet here that my local pharmacy made up, like Sanford Medicaid expansion will only do Zubsolv. They'll let me do 2 tabs of Zubsolv 8.6, but if I want to do Zubsolv 2.9 or 5.7, I can only do 1 tab per day. It just doesn't make any sense to me. But yeah, so she's on Suboxone film or tablets, you said?
These are the film. These are the tablets because they're cheaper.
Okay, and she's paying out of pocket for those?
She is, yeah.
Is the generic buprenorphine naloxone cheaper than the Suboxone name?
That's the one that she's actually using. And we found that if you go to Walmart and get the buprenorphine, I just say Suboxone because it's easier to say. But
okay. Yeah, because I was going to say, I didn't know Suboxone had tablets.
Naloxone.
Okay, all right, yeah. Yeah, that's a tough spot. Yeah, she's got way too much responsibility, with all those kids and a baby and then her boyfriend and then trying to work. Oh, I don't know. Anybody else have any suggestions on what to do? The only other thing is I could think maybe not doing 1.5 in the morning, maybe do 3 times a day dosing, say 1 in the morning, a half at noon or something, and 1 in the evening. Maybe 3 times a day dosing would make her feel better, kind of back to that mentality of an addict. I know these drugs are made to be 1 time a day dosing, but I think out of the 30 patients or whatever I have, I only have 1 that does 1 time a day dosing.
Right. She was at that, and we've come together, and she actually says it works better for her now taking it twice a day. Because she did even get all the way down to taking all of it once a day. And she said it ends up better. She doesn't get tired or anything in the morning if she takes it all. She takes it spread out like twice a day. But
man.
So Wendy, does she have CPS involved, or she's just worried about it?
So, and that's where a little bit, it's a little cloudy because I don't have a relationship with the reservation because they're their own entity. They're actually quite a ways from us, really. So usually what she says, and that's how she ended up with the extra children and stuff, is they try to keep them in the family when they pull them. So there really are no resources. Her dad helps out a little bit with and I think the nephew actually is going to move out pretty soon. So she's down, but you'd think the older kiddo would help out and actually be beneficial, but yeah, so little resources. I think her mom's gone too. Her mom has passed away. So I don't know what kind of resources there are on other reservations as far as like therapies and stuff like that, if anybody knows.
I guess on our local reservations, they do have like mental health, behavioral health counseling, and a lot of my Native American patients will participate in that. I strongly encourage they participate in something, whether it's counseling through their local facility or AA or NA, and most of them are pretty good about that. So they have those resources available. Most of them use it. I guess I'm not sure what you have available there. You said you're mostly in Minnesota?
The reservation is, yeah.
Okay. Yeah. Do they have any kind of resources like that there for them, or is she willing to participate?
She's been trying to steer clear of there because she knows quite a few people. And actually, when she first started, I was really worried that she was just diverting And we've talked about it before. She said it's big in her culture to share. In the, you know, if you have 3 tablets and you have 2 friends that are suffering, then you give them some, because that's the culture that she was brought up in. And so we discussed that extensively, and I think she was actually overusing it. Hindsight, I don't think she was actually diverting it or giving it away. But what was the original question? No resources.
Yeah. Resources, yeah.
Oh, because she can't, because she doesn't want other people to know where that she has addiction.
Sure.
Kurt, it looked like you were wanting to say something.
Sorry, yeah. You know, we've actually, for especially some of the rural folks, we wrote some grants. Actually, the USDA has some grants for opiates, and SAMHSA has some grants. And we wrote some grants that tie in some medication dispensing units. Like, I don't know, Dr. McLean, out in Vermont, they were using them.
Yeah.
Where, you know, a certain time of day, it will actually, you know, kick out the medication. And in a way, especially if somebody you do have some concerns about diverting, and they tend to, you know, not be consistent with, you know,